Hi guys, Dr. Douglas Gillard here. Welcome to another video. This is a sad one. It's the story of Tom, who's had 4 failed lumbar surgeries. And I probably could have made a video on each one. There's some crazy things that have happened to him. I don't want to tell you right now, I don't want to spoil the video. But even you seasoned pain management docs and surgeons, I don't know if surgeons watch these things, probably not. But for sure, primary healthcare providers, pain management guys, you're going to learn something from this because you're going to see something that you'll probably never seen before. It's a rare complication with the use of bone morphogenetic protein. So, and I want to thank Tom for letting me publish this. It's very kind of him. It's definitely going to help somebody out there, so thanks, Tom. And then just one plug for myself. I do offer a coaching service. It's a consultation where you and I go over your MRI images, CT, discography, whatever you have. We go over them together with a fine-tooth comb via GoToMeeting. So if you're not satisfied with your diagnosis or someone said you don't have anything wrong with your MRI and you don't believe that's true, send me an email. My email's down there. Where is it? chirogeek@chirogeek.com. You can go to my coaching service page. You can read all about it at chirogeek.com. and learn about it. I'd be happy to talk with you. Okay, let's get to business now. All right, here we go. The title of this is Recombinant Human Bone Morphogenetic Protein 2 and its fusion complications. And we're calling him Tom. That's not his real name, but let's check out his story. So he's a 40-year-old male. He originally consulted with me in December 2016. His ODI is Oswestry Disability Index, which everybody, all you primary docs out there, make sure you get that score because it means a lot. Everybody's pain is subjective, and anything over 50-ish is definitely, and they've been there a long time, that's a candidate for surgery. So he's battled, he's 46%, he's battled low back pain since his last teens. He's not had any leg pain, which he got after a disc herniation, as we'll see. He's told he has a slight scoliosis, also a transitional segment. Here, let's take a look at his spine. So you can see this is a scout view from a CT scan. But you can see there's the 12th rib. We're missing a full rib on the other side, so he's already got some funkiness, as I say, going on here. We count the bones now, so that's T12, 1, 2, L3, L4. Where's L5? It's sacralized. So this is called sacralization, or this is a transitional segment. You can see a little spina bifida here as well. So you got to be careful. In fact, the first surgeon actually called this L5. Second surgeon called this L4. Technically, this is L4. So even the surgeons got these numbers mixed up. Luckily, they didn't screw up the surgery level. All right, here's a CT mid-sagittal view. You can see the vertebral bodies here. Now we're right, this is a mid-sagittal, so we're cut between the pedicles. You can't see them. The thecal sac would be right in here. Remember, there's no spinal cord down here. There's a thecal sac. There's the spinous processes. So first question, students, what do you see? I see a problem already. Good, some of you caught it. There's a retrolisthesis, right? So you always check the corners of the vertebrae to make sure they line up. These are all pretty good, but this is back. That could indicate instability. And then we can see the rudimentary disc space. Here we got full disc spaces at 4, L3 and L2. Great. But L5 there's not much movement here. It's almost complete sacralization. All right, so the first injury happened in 2012. The patient wasn't exactly sure what he was doing. He was in gardening maybe, or he's got to lift some 50 pounds at work, so maybe it was something in work. But he had developed back pain and some pain down the leg for the first time, also into the groin. So students, without even knowing anything, when you have quadricep pain on the left side and groin pain, what level are we looking at? Probably L3, right? There's maybe L2 or L3 typically. An injury to those nerve roots typically put pain into those dermatomes. Middle back pain, the usual back pain, not a big deal. So we tried physical therapy, which is great. Tried chiropractic care. Tried what's that mean? That is a transforaminal epidural steroid injection. All of these failed. So the next step is to go see the spine surgeon. Disability was high enough. Here, he also got an MRI. So here's his MRI. Let's see if we can figure out what's going on here. Can pause the tape. Give you a second to look at that. Okay, good. Some of you saw it. So if you look down here, here's the L5 or the L4 vertebral body here. This is a cut through the left intervertebral foramen. This is normal. There's the exiting L4 root. Okay, and there's the IVF, the intervertebral foramen or the neural foramen, or the hole where the nerve leaves the spine. And now look up here. We got a big mess, right? There's like a double colored thing here. So it's probably a sequestered fragment with the main body of the herniation right there. He's never had surgery before, so it's not scar tissue. Now we look over what this orange is. That's the cut line. So whatever that goes through, you can look at over here. So remember, these sides are reversed. This is the right. This is the left. So it looks pretty good over here. There's the, what is that thing? It's the dorsal root ganglia, or the exiting nerve root of L3. How about this? Still within the thecal sac, but that's the traversing L4 nerve root. That's going to bud out of the thecal sac and become the exiting root down below. But now you can immediately see over here we got a big problem, right? And there's a really broad-based disc herniation. And here's the poor dorsal root ganglia on the left. So it's getting pushed way out of position by this herniation. This one's right next to the disc. This one's pushed way out here. So that matches his symptoms perfect. It's a pretty simple case. Only it's not so simple. Let's take one more look here. There's a cut, one cut below. It gives you the full magnitude of this herniation. It's pretty big. So the problem with these type of herniations is you can't get them from the traditional approach. So the traditional approach is you come between the lamina here. You take the thecal sac and you retract it, push it that way, and the paracentral zone herniations, which is the most common type by far, it'll be hanging out right here. This one is out far lateral. It's in the distal part of the intervertebral foramen, and it's out far lateral. So the only way you can get it is you have to come from the outside. That's a transforaminal approach or far lateral approach, whatever you want to say. And the success rate of discectomy from that approach isn't as good because the dorsal root is very delicate. It doesn't like to be fooled around with. So the surgeon's got to be super careful. We also got a little bit of ligamentum flavum thickening. Here's this black ligamentum flavum. And we got an extra little bundle of it right here. Could possibly be a facet cyst. I think one radiologist thought it was. But it could be just some extra thickening. It's a problem. It should be shaved down during the surgery as well. All right, so first surgery, microdiscectomy and decompression. Decompression just means that they're doing this resection of ligamentum flavum, maybe a foraminotomy, taking some of the foramen out. In fact, I think that's what he's going to say here in a second. But the first crazy thing of this case is the surgeon uses a translaminar approach. I mean, you can't get the herniation out here. How can you get your instruments in here and get all the way out here? It's impossible. So this was a failed discectomy without even, I mean, there's no chance of it working. So he was also told that he moved about 50% of the bone. So that's probably going to destabilize the joint. I mean, I don't know who this surgeon was, but ridiculous, in my opinion. Just to show you again the approach line. So translaminar approach comes right through here. And most of the herniations occur in this zone here. His was way out here. So the only way to approach is to come out through this way. And you can see there's the exiting root is right there and the dorsal root ganglia. And it's a delicate surgery. So surprise, surprise, surgery doesn't work. So first, the surgery helped a little bit on his, that should be left leg at first. But the big notice was it caused a lot of low back pain. Because they took out 50% of that bone, so that's in the facet, that's going to cause back pain. But within a week or so, the pain returned with a vengeance in his left leg. So now he's got really bad pain on the left thigh. Low back pain got worse, so now he's miserable. He can't work. He was able to work before the surgery, now he can't work. So the surgeon ordered a new MRI. So now let's do a quiz. Take a look at this and see what you think. Okay, now we see some new stuff here. Okay, first of all, here's that same view. There's the L4, the good level, and you can still see that big thing. It's got the nerve chased way up to the top here. So the herniation looks almost exactly the same. You know, surprise, surprise. That's because he couldn't get it. You know, he said this is a recurrent herniation. I don't think it was. I don't think he got the herniation. But now you look on the overhead view here, and this is through the left IVF. You can still see the monster out there. It's pushing the dorsal root ganglia way out of the way, just exactly like it was before. But now we got something new. What in the world has happened here? So you go on this side, you got a clear channel. I mean, it should be bigger than this. This ligamentum flavum is compressing this a bit. But there's the right dorsal root ganglia. There's the traversing root. No problem. What the heck's going on here? Well, this is a good lesson for you guys. Now, without gadolinium added to the MRI, we would have no clue. That could be a herniated disc fragment. It could be a facet cyst that's grown from the trauma of remember he took about a chunk of the facet off during the surgery as well. It could be scar tissue. So because we have gadolinium, I think I've talked about this in other videos, the gadolinium will light this thing up. This is living tissue that has been added. The body's trying to scar the region up, and therefore it's going to have a lot of little blood vessels through it. The gadolinium will course through all these blood vessels, and when we look at a T1 image, it turns it really light colored, and so light that you could say it almost disappears and makes it go away. Disc herniation fragments, they may have a little bit of blood vessels in them, but not much. So they all tend to stay black, but scar tissue disappears. So we're going to look to see what happens if it disappears or not. I think I just blew that up there for you. All right, I'll give you a second. Here's the contrast, the gadolinium image. This is the T1 without it. Okay, what do you think? So here's that other picture, the T1. Nothing here, right? This is wide open. This is all blocked with something. But when we add the gadolinium, see how it all kind of disappears. It's much lighter in color. You can't tell the difference between the color here and the color here. But now with the gadolinium, look how black this is and look how big it is. That is the herniation, and it's a big one. It looks exactly the same. The guy I'm convinced he didn't even touch it. So he's got a recurrent disc herniation, or he still got the same from the first surgery. The poor guy's still suffering. So this stuff, all of this, unfortunately, it's scar tissue, epidural fibrosis. But at least there's not a lot of scar tissue way out there, so that's good. Okay, there's just another image of it. All right, so we got to have another surgery. He can't work. He's in horrible pain. Back he goes. And now the guy who did the first surgery has gone. He moved down to Florida or somewhere. And so he's assigned. He's signed a new spine surgeon. Don't ever be assigned a spine surgeon. You need to go do your due diligence and your homework and pick one out for yourself. You know, I got a video on how to pick them out somewhere too. But he's assigned a new surgeon. At least this guy's off to a good start. He tells him he's going to have to do a revision discectomy, but he's saying that he's going to have to give the patient another scar because he can't get to the herniation through the transfemoral approach. Can't use the same scar. So he's using the correct approach, which tells me the other guy, I don't know what the other guy was thinking, because it's the same herniation, but at least this guy's going to approach it correctly. All right? So October 14th, the far lateral microdiscectomy is done on the left at L405. So the outcomes, within a week of the surgery, now he's even worse. He's got horrible low back pain. His left leg is still hurting, but now his back pain is just driving him crazy. I think did he go to the ER? I can't remember, but he was really, really bad. The new surgeon, or the second surgeon, he ordered some imaging, And he didn't order a CAT scan. Is that true? No, I think he did order a CAT scan. Yeah, we'll see the images in a second. But he said everything was fine. There's nothing wrong with you. The surgery was a success. I don't know why you're having pain. I'm sorry. There's nothing I can do for you. You need a spinal cord stimulator. Okay, that's really the end. That's kind of the last Hail Mary type pass. Sometimes they work okay, sometimes they don't. But the patient wasn't going to accept that. He kind of sensed something was a little funny, and he got a second outside opinion from a different surgeon from a different group far away from this area, which is great planning, a great strategy. Everybody should do that if your surgery fails. Get out of that practice. So the new images, let's take a look at the new images. So this is after the second surgery. I'll give you a second. All right, what do you see? Well, now there's even worse here. You can see there's that kind of reference, L4 IVF. There's the exiting root. Everything's great. Now we got this big giant thing in here. Okay, and then we got all this stuff. The poor nerve has got nowhere to go. It's really chased up to the top. When we look at the overhead view, this nerve looks the L4 traversing looks a little swollen. But now we got this thing. Okay, this was all one color. Now this has gotten even dark. So it could, what is that? Is that scar tissue? We're going to have to use the gadolinium again to see. And then this looks even worse. Look at this thing. Is it scar tissue? Is it a herniated disc? Can't say for sure, but whatever it is, the nerve root is tangled up in it and way out here. So let's go to the gadolinium now. There's just another cut. Oh, wow. We got another problem. Before we get to the gadolinium, there's a cut. This is a cut down one level. And now we can see, okay, there's the dorsal root because it's a lower cut. You can see it more in this location. But look what we got over in this facet. This is T2 weighted, so anything with water in it shows up bright white. So that's a giant seroma. The radiologist thought that was a facet joint cyst. I don't think, to me looks like a classic seroma. Facet joint cysts can't grow that big and that fast in this amount of time. So that's a seroma. Remember the patient is normal. There's nothing wrong with him. That probably should have been drained because it's that big. You can also see it on the view here. So now he's got a seroma. Now let's go to the contrast. So T1, C plus means contrast. Give you a second, what do you see? All right, well, a lot of that material that was up in here has disappeared. So now he's got more scar tissue up where the exiting nerve root is. Remember, he didn't have much here the last time, but it's disappeared. Remember on the other video or the other shot, see all that? It's like, what was that? We thought maybe it was a herniated disc. No, that all disappeared. So that was scar tissue. Okay, so we're left with a nerve root here. That is just an indication of fluid. This didn't disappear. There's scar tissue we know from the last one, but that's just all fluid in here. Okay, it does not look like it was a facet joint cyst. It would probably enhance and disappear and be white. Fluid tends not to do that. So to me, that's just a big seroma. All right, so we got scar tissue out here now that's disappeared. There looks like there is a little recurrent herniation, but not nearly as big, so at least he got most of the herniation out. But we're not done yet. So as if he doesn't have enough trouble, let's take a look at the CT scan. Okay, I'll give you a second, students. Or whoever else is looking at this, whoever else is playing along. Okay, you see it? Okay, remember the parts. Let's look just a review here, the L4 bone. Remember, this is the superior articular process. This is the inferior articular process. Pars intra-articularis is in the middle. The whole ball of wax is called the articular pillar. Okay, see it now? Look at that black line. That's a fracture. The surgeon fractured his inferior articular facet. He told him there's nothing wrong with him. I don't know what he's thinking. I don't know if he didn't the radiologist missed it too. This is the strangest case to me. If we go to the coronal view, okay, here's the posterior arch of L4. Okay, there's the facet joints. There's the articular process, lamina, spinous process. Inferior articular process would be right in here. Okay, you see it? Big fracture. It's fine right here. We got a huge fracture right through there. Not only that, if that's not bad enough, notice the width of the facet joint here on the right side. The left, look how big it is. This thing is shot. This is completely unstable, which makes sense because he took off. See how the facet joint, this is the most superior or anterior part of the facet joint is here. Where's this one? The surgeon said he cut it away. He did cut it away. So it makes this vulnerable to fracture. So, that was you can't blame that all on the second surgeon. This thing was just an accident waiting to happen. But the second surgeon should have taken the time to look at the images and at least got this right. Okay, so we got a problem. So now what are we going to do? Third surgery. So he stays with the same surgeon, and the surgeon says that you need a interbody fusion. And we talked a little bit about interbody fusion in that BMP video, so go look at that if you're lost, or go look at my fusion page on my website. But he specifically a TLIF, transforaminal lumbar interbody fusion, was recommended, which is perfect for this because this facet that's all destroyed and that inferior articular process can be just taken right out of there, and they can grind that bone up and they can use that as graft material or as fusion material, right? If you learned from my last video, it's like when you fuse two bones together, you need something to grow them together, and that's the material. He wasn't told this originally, but I got the records to confirm this. He did use BMP, and it was soaked into a sponge and slid into the cage. The patient says he was never told. He didn't even know what the heck BMP was until he consulted with me. So he had no clue about it. And this whole surgery is clearly off-label, right? You'll remember from my BMP video, only anterior lumbar interbody fusion, Tiger Woods surgery. That's the only one it's allowed for. So this is from the last video. Remember a TLIF, they go in and they rip this facet out. They take out most of the inferior articular process. They basically destroy this area. They use this bone. They stick this bone, grind it up, and put it inside the cage. To get the cage in there, they have to do an annulotomy. They have to cut the annulus open, slide the cage in. It's packed with BMP and the little sponge and the bone. I'm not sure if he put the bone around in the front or in the back. It looks like on the CT scan that he did. He did a good job. He went the extra mile to put bone around the cage. A lot of surgeons, I think they're lazy. They don't put any additional bone in here. They just put bone in the cage, and that's it, and hope for the best. It's really better. The ones that I know and work for all pack in front and pack behind. So it takes a little longer. They get paid the same, but it takes a little longer, but I think it increases the chances for fusion. Anyway, so there's a TLIF. So let's see what happened. So for about a month, he felt pretty good. So he thought he was out of the woods. He's really happy. But then a new pain started that he's never had before in that same left leg. In the posterior of the leg and the anterior of the leg, just burning like it's on fire. Thigh pain was doing, the quadricep pain, front of the thigh was doing better. But now we got a new pain. Then the low back pain returned, and then the thigh pain. Then everything just kind of fell apart after that. So patient never had this sort of pain before. New images were ordered by that surgeon to see what went wrong, and let's see if you can pick this out. This one's a little harder. Okay, here's the T2 weighted images. All right, so here's the cage. So this was on the left side, just the opposite of my drawing. This was on the left side. Here's the pedicle screws that holds the construct together. It's like a cast to let for healing. But if you could see on this side, see how this comes to a little triangle here? There's nothing in there, but look at this. Look at all this stuff. What in the world has happened here? And that's a little harder for you to see, but when we get to the CAT scan, even my first quarter students are going to be able to see what's happened. If you go back to the hole again, so now the hole looks really funky. We know it's got some scar tissue in it, but look at all this stuff. It's almost like, well, let's go see. I don't want to spoil the surprise. Let's go look and see the next image. Here's just another cut, and you can see there's a huge mass here. It's way bigger than the scar tissue used to be. All right, CT scan. Let me give you a minute, see if you can figure it out. Okay, what do you got? Yeah, we got a big problem, don't we? This is a CT. CT scan shows bone, anything white. This is a vertebral body. This is a cut through the disc, but you don't see soft tissue. You see bone. So look over on the right. You can kind of hallucinate that'd be the L3 exiting root. But the neural foramen look good. Here's the facet joints. Okay, looks good. Not the greatest fusion in the world. I see some bone there, but okay, I'll buy that. It looks fused. But what in the world do we have here? You guys have never seen anything like that. So that is, you can call it a BMPoma, a tumor of bone. Officially, that's heterotopic bone that has leached out of the disc, got into the epidural space, and then it's done what bone laced with BMP is supposed to do, or with osteoblasts, it has done what BMP is supposed to do. The BMP has turned into bone, and it's grown a huge spike of bone here. His exiting root is all tangled in. It goes out in here as well. It's not fully developed. Now when I go down one more cut, it's even worse. See that? That's all new bone formation that shouldn't be there. Right? Here it is from this view. We thought maybe it was scar tissue. It's not. The CT scan goes right through scar tissue. That's pure bone. So he's got a big bony mess here. Facet looks okay fused, not solidly fused here. Okay, but the problem with this is that the surgeon never told him about this BMP, this BMPoma. It should have been treated immediately within 6 months. He could have untangled it and maybe had a chance to get rid of that leg pain that the patient's now suffering, but he didn't. Here's just another view, a coronal view. You can see, I think I'm just checking for fusion. See, these are normal facet joints. These look fairly well fused here. So not too bad of a fusion. Here's a TLIF or a PLIF was supposed to, posterior lateral fusion was supposed to be done. He didn't do, I don't think he did that. I don't see any sign of posterior lateral fusion. You should fill the intertransverse beds up with fusion material, bone graft material. Usually you'll see struts of bone running through here. So I don't think that was even attempted. Okay. Okay, so now if you guys are lost, here's my little cartoon of it. So what happened to this guy? So BMP was placed inside this cage, and the patient was closed up. All right. There's no BMP when they close up because they irrigate this, they suck it out. It's sterile environment. But after they close the patient up, this BMP, for whatever reason, leached out. It leaked right out of the disc through that annular tear, that the incision hole, the annulotomy, and now it leaked all over the epidural space. So now we have BMP floating around in here, and then BMP is going to do what BMP is going to do. It's going to turn to bone, and that's exactly, this cartoon shows exactly what's happened. So it's hard for me to believe that a small kit, that's 4 milliliters, I think, a very tiny amount was used, because he's got this stuff everywhere. I've seen a lot of these BMPomas before, this heterotopic bone, but they were done with 12 milliliter kits. A lot bigger doses of that, but who knows? Maybe did he use a bigger dose than he thought, or who knows what happened? But it just seems strange to have so much bone with just a small kit. So what's the data here? So I talked to the patient in December, and mind you, he has no idea what BMP is when I talked to him. He doesn't know anything. He was told he needs a spinal cord stimulator. He wants somebody to go over his CT scan and MRI images, and there's got to be something I can do. So I was shocked when I opened up his CT images. I'm like, you got to be kidding me. You don't know what's the matter with you? But he didn't. So low back pain, really bad, 10-8. Left posterior leg pain, 6-10. He's got 5-10 pain in his leg and foot. 50-50 back pain to leg pain. He's on opioids, right? Percocet. Lyrica calms down the nerves. Baclofen is a muscle relaxer for his back pain. His ODI is about 46%. He has to work. He can't lose his insurance, right? He's trying to figure out what's the matter with him, so he has to keep working full time. He has to lift 50 pounds 3 times a week, killing him, but he has to do it. It's conveniently positioned for him. So obviously what I told him is, you got hydroxylene root. That's where your leg pain's coming from. The fusion looked, and I forgot to show you, it was the fusion solid. The fusion was solid, the interbody fusion. See the struts here? That's solid fusion. Remember the cage was placed way up here? How do we got bone back here? So I don't know if the BMP leaked out of the cage and caused that. I'm thinking that the surgeon probably packed some of the morselized bone, the ground up bone back here. It's also close to the back margin. And I have a cut. This cut is going right through this BMPoma. So I send him to, when I get crazy cases, there's a clinic in New York called Hospital for Special Surgeries. I'm not affiliated with them. I don't know anybody there. I've been doing this a long time, and I've had some good luck with other clients. So I said, go to HSS. They're the ones, by the way, that did that kind of that MRI where they sent that patient with all these problems to 10 different MRI centers, I think it was, and kind of like a spy to see how good the radiologists did. And they did terrible, like 50% of them got stuff wrong. That was their creation. So I like this clinic. Plus, I've had great results. Plus, they have some of the best surgeons. If you do your due diligence and check out the surgeons here, their pedigrees are really, really great. But anyway, and he also went to, I think he went to Mass General for another opinion, which is great. The more opinions you can get on this, because he probably thought, well, Dr. Gillard, what heterotopic bone? Why wouldn't the surgeon tell me? He's probably doubting me. But he went to both of these surgeons. They completely agreed with me. He's got heterotopic bone formation. HSS thought that they could go in there and decompress the nerve root. Very dicey surgery, only because he's waited almost 2 years, and it's probably solid bone. You probably have to burr the bone out of there. The other surgeon said, you know what, the damage has been done to your nerve root, and I don't think it's going to do any good. So the patient opted to go with HSS and see if he could get some further relief, and we'll see what happened. So the first surgery was done in May 2017. Let's see the CT results. Well, here's the results, right? The objective result or subjective results. The surgeon said there was a BMPoma, with lots of scar tissue. The nerve root was tangled up. He did the best he could to decompress it. Patient actually felt pretty good for a couple months after the surgery, and then everything came back again. So what that usually means, 2 months is about 8 weeks. That's usually the time when scar tissue comes back. That's the trouble with removing scar tissue from a surgery. It doesn't stay gone. It just grows back again. And oftentimes, he's lucky it didn't get worse, because oftentimes it can grow back with a vengeance and cause even more trouble. But that's probably what happened. So to get the BMP, the full decompression, he actually removed the instrumentation on the left here. So there's an x-ray of him. You can see the pedicle screws and rod is gone. Now you can see that transitional segment really nice. See the spina bifida here? There's one part of the spine, is 2 parts. There's a hole through it. And you can see the transitional vertebrae, huge spatulated, there's a little neoarthrosis here, but there's probably hardly any movement. I see complete fusion over here. That's like the least of the problems. Well, all right, so here, drum roll. Here is the work from the HSS surgeon. So apples to apples. So this cut is almost exactly the same. I can see the little dot of the cage, both cage. Here's the little dot of both cages. So this is the same slice, 12 of 16, 3 of 18. It's way too much time has went by. But let's see how he did. So here's the original BMPoma, right? And you can see where he took all of this out. So he got pretty good decompression. Took me a while to figure this out because the only thing that I was upset about when I got this CT scan, there was no sagittal. So it was hard to tell exactly what level you were at. But I figured it out by carefully comparing it to the other ones. So he wasn't able to get all the BMPoma out though. So got heterotopic bone that's still attached to his thecal sac. Why? He could have taken it out, but he would have ripped holes in that thecal sac like crazy. He would have dural lakes. That would have been a nightmare. So that was, he cut it really close, but that was the best he can do. If I go down one cut, you can see it doesn't look quite as pretty down here. Still some posteriorly, this looks thicker. But I'm convinced he got pretty good decompression on that nerve root. And because the patient got better for the first 2 months, I would say, yeah, he got good decompression. But the trouble is this filled in with scar tissue again. So unfortunately, there's not much more you can do. So last time I talked to the patient in August, his back pain was 610, still had the thigh, leg, and foot pain, 50-50 ratio. No medication, so maybe got a little bit better if he got off the opioids. That was excellent. And he could sit through a movie, out to dinner, depended on the chair. He was still working, dreading lifting that weight 3 times a week. He said if it was a bigger facility where he had to do this every day, he wouldn't be able to work, which is understandable. This is too big, by the way. You shouldn't lift more than 25, 30 pounds after surgery like this. I'm worried that it's going to blow out the disc above and below. Remember the domino effect. So we'll have to keep an eye on that to see how he's coping with that. So final assessment, the condition would be a failed back surgical syndrome, the dreaded FBSS times 4, right? He had 4 of them, and he's stuck with residual chronic back and leg pain, moderate disability, 50% on the oswestry about. He should have reminded him to use good biomechanics when he's lifting. Always lift with 2 hands. Use your knees to lift, not your back. And you just have to monitor for adjacent segment disease. Keep your fingers crossed that it doesn't get worse. Final comments. It was really frustrating for me. I wish you would have come to me sooner. I could have caught this earlier and got the ball rolling. He came to me 2 years after the fact. We caught it, but it's kind of too late. But yeah, it's a shame he couldn't get to me earlier. I think the nerve would have had a better chance, or at least those fibers of the nerve that are causing his leg pain would have had a better chance. And the final comments to any of you surgeons who are watching, new surgeons or fellows or those who are doing a fellowship or residency, don't be an ostrich. If surgery doesn't work for your patient, it's your job to figure out what happened. Don't just brush it off. Or you got to order a CT. If you're using BMP, you're not going to see it very well in the MRI. You need to get a CT scan to see if it's heterotopic bone. And then look at the images with your own eyes. Don't rely on the radiologist report. They got 8 minutes on average to go through a patient. 8 minutes. I spend, in my coaching, I spend 45 with you at least. A lot of people go for 90 minutes, and we really go through these step by step, and we really get to know what's going on with your spine. So don't rely on the surgeons. Don't be an ostrich. Get your head out of the sand. All right, thanks for watching. I hope you enjoyed this video. Again, thanks go out to that my client who graciously allowed me to publish his story, and thank you so much. And just a final plug, if you do want to talk to me in person, send me an email, chirogeek@chirogeek.com, and I will send you some links. You can learn more about this consultation service I call a coaching service. We'll go over your MRIs together. We'll talk things out. We'll make an evidence-based plan, and hopefully I can help you. Check out my testimonials. I got about 60 of them now. from priests to medical doctors, chiropractors, physical therapists, you name the profession, I've consulted with them. So, okay, we'll see you in the next video.